I don't see the JAK inhibitor class as really being that first line therapy. It's not the thing we're going to grab to, nor is it the thing that most patients who are just entering that pathway of a systemic therapy, they're also not going to choose that medication first.
Welcome to the Learn Skin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Join us as we delve into the art and science of skin health in today's episode.
Hey, Raja, can you say the thing I told you to tell them?
Of course. We are board-certified dermatologists. This podcast is meant for educational and informational purposes only and is not considered medical advice, nor does it serve as a substitute for professional care by a doctor or other qualified medical professional. All opinions shared do not express the views of Learn Health, Inc. Let's get to the good stuff. What's up, everyone? No Hadar, it's just me running solo today for the Learn Skin podcast, but we are going to have a great time. I think there's been a lot of conversation around these new emerging therapies known as the JAK inhibitors, the Janus kinase inhibitors. And we have an expert that has been speaking on this topic for a really long time. There's a lot of questions around safety, efficacy. I think we're going to clear all that up today and get everybody up to speed. So without any further ado, I'd like to introduce Dr. Jason Hawks, who's a really good friend, but a master clinical dermatologist and a clinician and researcher. In many ways, he's a renaissance man within dermatology. Jason, welcome to the podcast, and I'm super excited to be talking about this topic with you.
Thanks, Raja. Happy to be here, and this is a great topic. I love it. It's a great intersection between immunology and clinics, so I'm excited to be here.
You know, I think back to our last podcast, and we talked about how it's not algorithmic at all when we think about medicine. We do a lot of customization in the room, and I still think fondly to that podcast, and I think it makes a lot of sense with today's topic. So maybe we can lead into where the JAK inhibitors have gotten a lot of their approvals so far, especially in the area of atopic dermatitis. But can you give us an overview? What is a JAK? What is a JAK inhibitor, and why should we care?
Yeah, I think it's really important because medicine traditionally has gotten better and better over time. We start with sort of crude treatments, and over time they get refined, they get more specific, and, they get more targeted. And that's been a traditional, direction for medicine. But interestingly, the JAK inhibitors kind of deviate a little bit from that, in that we came from these crude treatments like, broad-acting medicines, methotrexate, cyclosporin. These are non-specific. They hit big portions of the immune system. And we eventually came to biologics, which are, I often talk about these snipers. They're very, very specific. They hit one target, and they have an effect that way with really no collateral damage for the most part. But with JAK inhibitors, we've kind of gone a step backwards in that concept. Not the step backwards meaning we haven't made progress, but we have a therapy that's less of a sniper, more of maybe like a shotgun, if you want to use that analogy, but they act a little more broad than biologics, for example. But it's an important concept because we start looking at this small molecule class. So now, rather than a protein that acts outside the cell, we have these small molecules that act inside the cell, but they are a little less selective, meaning they hit multiple pathways. But that has some advantages when we start looking at complex disease states where, maybe inhibition of one pathway isn't enough. So we start looking at diseases like atopic dermatitis, which has, multiple pathways, HS, for example. I think these are going to be clinical scenarios where backing up a little bit and hitting multiple pathways may actually be beneficial for important concepts.
Yeah, Jason, I really appreciate that point because I think with the biologics, we got so specific that, like you said, the side effect profile really went down. But at the same time, I think we've come into an era where we realize these diseases are multifactorial, and there are many pathways that may be coinciding together, or at least multiple pathways. And I think you're right. The JAK inhibitors now give us the ability to be a bit more broad and not just say single target, single molecule, single disease, but really, is it a single disease? So can you speak to this in atopic derm? Like, do you think there are multiple different pathways involved in atopic derm, and what makes atopic dermatitis complex?
We'll talk about this with atopic dermatitis, but I think as a concept, What one really important research finding we've had over really the last decade have been the idea that these inflammatory conditions, eczema and psoriasis, for example, have associated comorbidities. So by merely having one condition, you're at risk for these other conditions. So for atopic dermatitis, there are many. And when we talk to these patients in the clinic, we start to see this. They almost never come in with just eczema or atopic dermatitis. They often have asthma or seasonal allergies. They may have food allergies or nickel allergy, fragrance sensitivity, hypersensitivity to mosquito bites or arthropod assault. So we see that there's a lot more going on than just the eczema. And so this area of comorbidities has really been an interesting area in both psoriasis and eczema because this idea that if you treat the skin disease, can you modify or alter these other comorbidities? And for the most part, we haven't really seen that with a lot of these conditions. So in psoriasis specifically, we haven't seen that the biologics, even when the skin's treated really, really well, we don't see the modification of some of these comorbidities like cardiovascular disease. But eczema is really interesting because we see therapies like dupilumab, for example, that blocks IL-4 and IL-13, clearly has an impact on multiple diseases. If you look at the indications, the FDA-approved indications of dupilumab,
That's a great point.
you start to see that it starts to hit these conditions which commonly come together with these patients. But it doesn't work for everything. And so there are still other pathways that are contributing. And I think within atopic dermatitis, we also have these subsets of disease. Why do people get it very early on in disease, whereas others can literally develop in their 60s, 70s, or 80s? So we've got these subgroups, or what we call these endotypes within eczema, that we haven't fully teased out. So I think there's still room for improvement, and there are certain clinical scenarios where maybe having therapies like the JAK inhibitors that hit multiple pathways can be helpful. And it may ultimately change some of these comorbidities where some of the specific therapies like the biologics haven't worked.
I think all excellent points and really good discussion on atopic derm because, it is not a simple straight line diagnosis. I should say the diagnosis is there, but I mean straight line pathophysiology. Well, now let's talk about the JAKs a little bit more. Can you talk about what are the different JAK players that are there? And how are the medications on the market acting differently?
Yeah, so we kind of go back to the basic science of the JAK inhibitor class. So we have, 4 isoforms. We've got JAK1, 2, and 3, and then TYK2. TYK2 we won't spend a lot of time with because as we've learned through deucravacitinib's approval, for example, that it really plays more of a role in psoriasis. It's hitting cytokines like IL-12, IL-23, and type 1 interferons. So we really don't see that product playing a role in atopic dermatitis. So we're really looking at inhibitors that would block, either singly JAK1, JAK2, or JAK3, or a combination of those different isoforms. So right now what we're really looking at on the market are either what we call pan-JAK inhibitors, things like tofacitinib, which really kind of impacts all of the isoforms, or the approved indications we have now, where we're either blocking just JAK1, as you have in upadacitinib, or blocking JAK1 and JAK2 with baricitinib, for example. So we're really looking at, those different products. When we think about the impact of blocking one isoform versus multiple, we're really talking about how much of the immune response we're hitting. I think of JAK1 as, being a fairly broad acting inhibitor. It really hits some of the key cytokines, involves some IL-4, interferon, some of the key signals that drive eczema. And we don't have a JAK3 inhibitor, which would act very similar to JAK1, but it's a little more restricted to the immune response. And then JAK2, being very broad, it's going to hit the immune response, but it also hits multiple other aspects of the biology, which are not related to the immune response, and particularly the blood system, which is really the main reason why we've tried to avoid medications that block JAK2, because of the, collateral damage of blocking the immune response and the blood system. And so that's obviously raised concern in our patients who, we don't want to impact, their blood count, for example, or their platelets. And so these have been the products that have come out in terms of how they function.
Yeah, one of the advantages of the JAK inhibitors is that you don't need an injection. It's an oral medication. I'm sure there are patients that would really prefer the orals. Then we have this black box warning that's arisen for tofacitinib, really, and then became a class label. Can you speak to where do you see the use of JAKs coming into play, and how do you walk through the side effect profile, especially given that some of these newer agents aren't the same as the pan inhibitors, but they're more specific? How do you put that into context?
Yeah, so I think one important distinction is that we often talk about black inhibitors as being a class effect, but we have to remember that the deucravacitinib as a inhibitor of TYK2 doesn't have those black box warnings. We're really talking about JAK 1, 2, and 3. And that's because it has a very different mechanism of action. But the reason for the class effect, I think, was probably appropriate from the FDA's response, because what's known about the way these inhibitors work is that they do have a spillover effect. So their mechanism of action and how they inhibit these enzymes, they can spill over onto the other enzymes, but also at very high concentrations, or as the drug sort of builds up in the body, it starts to spill over into the other enzymes. So I think we like this idea that, I always say it's selective. I think of specificity as blocking one specific target, like the biologics. I think of selective when we're selecting a particular enzyme, but it has broader effects. And we like to talk about the JAK inhibitors, the JAK 1, 2, and 3 inhibitors, as being selective, but they're mostly selective, but they're not completely selective, meaning that they also hit the other enzymes. When we have that conversation with patients, we need to explain that we're trying to, inhibit one aspect of the immune response or multiple pathways that's more restricted than these broad-acting agents like methotrexate and cyclosporin, so that's been a huge advantage. But we do have a lot more collateral damage. I think the most important conversation we have with patients is this increased risk for infections. And I think one of the side effects that's really tied to the JAK inhibitors is these increased both bacterial but also viral infections. So we do see herpes infections, we see herpes zoster or shingles infections, and these are real, and there is an increased risk. It's not a dramatic risk that we see again with cyclosporin, for example, but it is there, and it's different, and it's definitely higher than the biologics. So that's one really important class side effect that we see. And the other one that we see, basically what we call acne or folliculitis. And they do vary between the medications, but the JAK1 versus the JAK1, JAK2 inhibitor, we see more with the JAK1, JAK2 inhibitor, but this is a specific side effect that we see. The other side effects are worrisome to patients, but they're very rare. So, there's this idea of blood clots or possible malignancies, cardiovascular disease, are these MACE events. And all of these have been reported, but they're pretty small when we get down to it. One drug in specific that I'm thinking about had, out of 2,500 patients between two trials, there was about 2 blood clots. So, we know that just the measuring of a side effect doesn't necessarily mean it's the medication, but you have a regulatory body saying, until we know more information, we at least need to put it out there as this is a possible side effect. And that's the way I explain it to patients.
Yeah, Jason, I think your point's a great one, because there's always that background rate of what actually exists in the general population, and we have to take that into context. Also, weren't the original black box warnings, didn't they come out of the comparative trial between tofacitinib and adalimumab in the patient population that was really more rheumatoid arthritis, perhaps an older population, had more risk factors? What are your thoughts about that in comparison to the typical patients that might be going on it, say, for atopic dermatitis?
Yeah, I think this is what makes it problematic to have a class effect, right? To take a warning and then sort of prospectively apply it on, other scenarios because the scenario differs. You're right in that when we started looking at patients with psoriatic arthritis or rheumatoid arthritis, they tend to be older patients whose immune system's already dropped down. They have comorbidities. They're often on other medications, have other conditions. This isn't a, overall generally healthy population. And I think that had an impact on sort of this class warning for the most part for the JAK1, 2, 3 inhibitors. But I also think there was an evaluation of the data. And the reason I say that for the newer medications is because we had this delay with the FDA in terms of the approval and the label for the medications, and I believe personally, again my opinion here, but I think they were taking in as much data as they could to compare it to the old data, but also they were kind of dragging their feet a little bit to get as much as they could. So I think they looked at the data for both past and current, but made this decision overall because I think they were worried about this class. I think there was concerns from what they saw initially, and so that reservation, I think, kind of colored the lens a little bit. But definitely the warning is in line with what they were worried about, and we did see those signals, as I mentioned. Now, a lot of those signals were low, but they were there. But it gets to this concept that just the mere measuring of something increases the likelihood of finding it. And if you're really looking for something and measuring things, that you're going to pick up some of these things that may or may not be related. Again, association is not causation. So I still think we don't really have a good understanding of how common these are. And we're going to need to see that over time in these real world studies.
Yeah, I think you're right. I think we're learning and gaining the experience as we go along. Now, the two that are oral, and I think there's one topical that's approved, topical ruxolitinib, and then we have the oral abrocitinib and oral upadacitinib. And I know the orals are a bit more, as you said, not totally specific, but more JAK1 selective. How do you approach their clinical use? In what scenario would you use them? And how do you put that in the landscape of these other biologics and perhaps even these other systemics that are the old guard when it comes to treating atopic derm?
Yeah, so I break it down as we really have three drugs, right? We have two JAK1 inhibitors and we have a JAK1, JAK2 inhibitor. And I personally, just because of my background in translational immunology, I think about it from the standpoint of what do they block, right? So when I think of JAK1 inhibition, I am thinking about the impact on interferon, IL-6, IL-15, IL-27, IL-21. These are some of the cytokines that JAK1 inhibition blocks. And when I think about JAK3, for example, as we talked about it still hits IL-15 and IL-21, but we don't see, and we see some interferon a little bit, but we start to see this different profile. So while I don't expect people to think in that same way, I think we do have to have this concept that what we're blocking, what cytokines we're blocking, should inform to some degree what diseases we're going to try to use it for, right? So interferon makes sense for eczema. It makes sense for alopecia areata, for example. And so when we're talking about which diseases we're applying it for, I think the evidence-based side of what we're doing is, do we have evidence that these particular cytokines have a role in a certain disease? And if they do, then these medications might work. And so with obviously JAK1 inhibition alone, it's pretty broad acting. JAK1 and 2 inhibition is going to have a much broader impact. So we're going to get potentially more coverage of cytokines that could be contributory, but we're also going to get more collateral damage. And so I see the main role for a lot of the JAK1 or JAK1/2 inhibitors as playing a role in diseases like alopecia areata, atopic dermatitis. I think the work in HS will be interesting, vitiligo. So there are going to be some subtleties between these different therapies for certain diseases, But that's also giving us some insight into what the underlying immunology is, because we can go back and say, okay, well, this didn't work in this disease, so these cytokines must not be playing a key role. And so I think we're just in the beginning. We're just scratching the surface about, how these, are going to work. And I think you take a disease like alopecia areata, for example, where we know that targeted agents don't work, right? We've done a study with dupilumab, for example, in alopecia areata. It only worked in a
Yeah.
small subset of patients that, had AD. That was a protocol I was involved in, but it didn't really work for alopecia areata. But we know that the JAK inhibitors, do work for a good portion of patients. So that gives us insight that there's differences in that immunology. So I think we aren't there yet, but the indications for multiple conditions is giving us this really great clinical experiment to try to tease out some of the immunology there.
I love your explanations when it comes to these JAK inhibitors. I think you put them into really nice context. Now into a clinical scenario, and I wanted to talk a little bit about the topicals. There's the topical ruxolitinib that's got the approval for atopic dermatitis. And I'm curious, how do you utilize that in comparison to topical steroids? We have topical tacrolimus or pimecrolimus, the calcineurin inhibitors. You also have crisaborole. What has been your experience with using topical ruxolitinib? And I'll just maybe even, throw my experience into the hat here. I find that the topical ruxolitinib is a great alternative against steroids, and it doesn't burn as much. And I find that there is a greater ease of use, even in sensitive areas. What has been your approach? And can you also talk about insurance coverage? How do you manage that?
Yeah, and this is a great topic.
It could be another podcast, right, Jason?
Definitely, absolutely. Like, the science of developing a topical therapy versus, a systemic therapy, there's a lot of nuances here. So while we've made a lot of progress in the systemic therapies, both in oral and injection medications, I would say we haven't made as much progress in the topicals. And it's interesting because we're still using very broad acting topical steroids. And those topical steroids, while they're effective at the immune response, which is why people like them, they work. Steroids definitely work. They have drawbacks, and those drawbacks are that you cannot use them long term without, the risk of thinning the skin. People have reservations, which is totally reasonable. And those are all reasons why compliance drops off with topical steroids. You mentioned stinging and burning. Well, this has been a problem that's plagued the non-steroid class. So even you mentioned
no
the
kidding.
calcineurin inhibitors, right? Crisaborole, like these are medications that have higher rates of stinging or burning, and that people already are having stinging, burning, itching, pain in their
Exactly.
cracked skin. So adding that, and then you take sensitive areas like the face or the genitals, like that's the last place you want to have stinging and burning. So this has been a problem because we haven't had great advances. We're getting there now, and I think this idea of the JAK inhibitor on topical really makes a lot of sense to me because we're able to get this broad impact. It's less broad than the topical steroids. It doesn't have the risk of thinning of the skin. You can use it in these sensitive areas. And if you're not seeing this, stinging, burning, then that's a huge advantage. Where the topicals have struggled, though, is there's one big advantage to the topical steroids, and is that they're cheap for the most part.
Yeah.
So that has been the limitation with these new topicals, is that their mechanism makes sense, the immunology makes sense. They might have great vehicles and they feel good as they go on, but if they're expensive or not covered, then most clinicians are going to revert back to that, default, which is I have something that's easy. I don't have to deal with the copay card or having them call a specialty pharmacy, etc., to try to get this topical. I can get $5 for a big tub of triamcinolone, for example. So I think there's still a lot of progress, but for the patients that have used it, it works well. And that makes sense because they have a medication they don't have to worry about, stopping or starting, which is going to make compliance better. And it does work because the immunology makes sense. It's hitting those key pathways that are driving the skin inflammation. So, I think we've started to make progress, but we still have a huge room to go where we can sort of minimize profits for these companies by making it affordable for patients. Otherwise, we're never going to change what's pretty common in default.
Jason, I think you hit upon something. And I think that was also part of the motivation for my question, is that our decisions on what we prescribe aren't always driven by just purely the science. A large part of it is, and we'll fight for it, of course. But I think the insurance coverage is that other piece where we're also trying to think through, while we're trying to, and I will say battle, while we're trying to battle against insurance coverage, like, I see 65% Medi-Cal in our clinics. We still have to send that other prescription because that patient today can't be waiting 2 weeks on appeals. We need to get them something. And I know you and I have talked about how writing the note, documenting accurately all the things that they have tried really makes a difference in at least, trying to get it through the gauntlet of getting an approval when a patient struggled so many times on getting something. Do you have any other comments on the appeals process when it comes to insurance?
Yeah, I mean,